MS is an autoimmune disease that affects the brain and the spinal cord. If someone could press play on that video. I guess it's not going to. Okay, that's okay. We won't worry about the video. So anyway, it's a demyelinating disease that affects the brain and the spinal cord, the central nervous system. And basically what happens is that the immune system attacks the brain and the spinal cord, and that's what results in the symptoms that we see with MS. Some of the common presenting symptoms are listed here, and I'm not going to go through all of them, but the two that are highlighted in red are the two that are more common in the African American community and oftentimes cause a significant amount of disability. Optic neuritis is where the nerve to the eye has been demyelinated by the immune system, and it results in loss of vision or decreased vision, and in some severe cases, blindness. Also, one of the more common symptoms that we see in the African American community is difficulty with walking, which is usually caused by spinal cord disease. So we often see the eyes and the spinal cord more affected, which significantly impacts people's everyday life and certainly their ability to function. When we talk about epidemiology, we really don't have very good numbers about the prevalence of MS, which is why I'm so excited about the work that the National Minority Quality Forum is doing in terms of mapping MS. We know that it is more common in people of Northern European ancestry, and we know that the incidence ranges somewhere between 6 to 17% in African Americans. But in communities like my own, in Atlanta, Georgia, if you look and walk into our lobby is full of African American people with MS. And our numbers are somewhere more like 25 to 30% or even possibly more in our patient population. So we really don't have a good database or way to measure how much this really occurs in the African American population. What we do know, however, is that although MS is less prevalent in African Americans than in Caucasians, it is much more prevalent than what we've seen in Black African populations. Now, we've talked a lot about race and ethnicity on how it may or may not contribute to disease processes, but in the case of MS, there are some things that are very similar and parallel between what we see in the Black African population or our country of ancestral origin versus what we see in the African American people with MS. So the first well-documented case of a Black African with MS in South Africa was described in 1979, and that may not seem very significant, but when you put into context that MS is a disease that's been described in the medical literature since 1868, that's a pretty big disparity. And it's not necessarily because people weren't looking. So back in the day when we did research studies before we had emails and all of that, people literally went kind of door to door, sent letters to neurologists and traveled all over different countries to examine people with MS. And in the 1960s, they could not find one Black African with MS, but certainly the first case was described in 1979. Since then, the largest case series that I've been able to find has been in 12 patients, but certainly that is not a lot of patients either. But what we see in this group is that they have a higher prevalence of what we call opticospinal disease, again, the optic neuritis that we saw on that first slide, or that second slide, and also the spinal cord disease, which generally results in more walking difficulty. And another thing that's very interesting is that we also found in that population that the optic neuritis, when it occurs, is more severe, and they have poor recovery and often can have it bilaterally, which results in, as I said, very significant visual impairment. What do we see in the African American population? This is a study done by Bruce Cree in 2004. And again, we see some of those parallels of what we saw in the Black African population. Optic nerves are involved, so vision is involved and spinal cord is involved. We also saw severe visual difficulty. Something on the third line that's very important is we saw shorter time to walking disability. So African Americans with MS have to use a cane or assisted device to walk an average of 10 years earlier than what we see in their Caucasian counterparts. And this is important because it generally is a disease that starts with people in their 20s to 30s. So we're talking about people that are very young that are having to use canes and walkers to ambulate because of significant disability. However, even in light of all of this, what we see at the bottom is that there was actually an earlier time to initiation of treatment. So many people would say, well, hey, Dr. Williams, it's worse in African Americans because we don't go to the doctor, right? So we don't go until it gets bad. But actually, there was earlier initiation of treatment because essentially symptoms were more severe at the onset. So if you have a numb foot that lasts for like a week and it goes away, you may not go to the doctor, but certainly if you can't move one leg, hopefully you would go to the doctor. Now I know some people that won't go to the doctor even if they couldn't move a leg, but hopefully if you couldn't move a leg, you would go see somebody about it and get it checked out. All right, other things when we looked at MRIs, we also saw significantly increased lesions in MRI. So when we're looking at this MRI on this picture here, those little white spots that we see kind of sticking up like little rays of sunshine, those are lesions where the immune system has attacked the brain. And that's what we're looking at when we're looking at MRIs of people with MS. And we saw that in the African American population, there were increased lesions, which also lead to more significant disability. And even some of the measures where we look at the actual effects of loss of the nerve tissue, there was obviously more damage in the African American population versus Caucasians. This is a study, abstract that I'll be presenting at a meeting in a couple of months, looking at the natural course of MS in a large clinical trial. So there was some pooled data from several clinical trials where we looked at the natural course in the placebo group of MS, and we can see obviously the red line at the top, which is the African American line, showed significantly more sustained disability compared to all of the other populations that are listed there. When we talk about access to care and utilization of neurologists and people with MS, there are disparities in the field of MS as well as many of the diseases that we've talked about today. And we can see when they looked at characteristics of people who were less likely to see neurologists, the third line there is African American, okay? So there are still disparities in the population with multiple sclerosis. There was also a study done in 2010 from a large registry of patients that probably has the largest number of African Americans in that registry, the NARCOMS registry, and there are about 1,300 African Americans involved in that. And they also found that a larger proportion of African Americans had never seen a neurologist who specializes in MS. When we talk about diversity in or the treatment of minority populations, this was an article that Dr. Amezcua and I had the pleasure of co-authoring, where we talked about some of these issues in terms of the research that's been done, the challenges to providing optimal treatment, including things like cultural sensitivity and socioeconomic barriers, and also talked about improved management of practice, which really involves educating not only patients about these differences, but also educating healthcare providers, because there are a lot of neurologists who really are not aware of these differences and who really don't know that these are things to be on the lookout for in their minority populations. In terms of unmet need, certainly we do not have accurate databases to really determine the true prevalence. In many other countries, there are very, very kind of accurate ways of measuring how many people have MS and the prevalence in different populations. We really don't have that in the US at this point. There's also a need for prospective trials looking at the disease. So much of the data we have is from registries and from individual practices where people have kind of taken a look at charts and things that have already been done, but there's not really a lot of data looking forward to see if those trends that we've seen prospectively kind of correlate with what we see retrospectively. Also, we need studies examining treatment efficacy. So like many of the things that people have said, how do we really generalize the treatments or the effects of treatments if there are only less than 1% of the people are minorities in these studies? So how can we generalize those things? So there are studies that need to be done looking especially at the ones that have already been approved, and certainly moving forward, it's important to increase recruitment of ethnic minorities in clinical trials. One other piece that's extremely important in our field is improving access to MS therapies. Unlike many other diseases, so fortunately we've been able to have lots of treatments. When I say lots of treatments, I mean 5 treatments in the past 5 years, which is really considered a revolution in our field. We have more than 10 treatments now available for MS, but most of our treatments are not similar in any way. So when a drug company says that I can't prescribe this, but I have to prescribe this, and they're totally dissimilar drugs, not in the same class, then it's difficult to really treat patients effectively because they're not similar, you know, and there's really no way to kind of tier medications that are not at all alike. And so that's a difficulty, especially if as a practitioner, you see these differences in disease and see that people are having a more severe course of disease and you can't prescribe an aggressive treatment without going through treatments X, Y, and Z that are totally unrelated and totally different. In terms of ongoing projects, some of the things that I'm involved in is developing a registry to look at risk factors in the African American population. Also, I'm involved in some prospective investigator-initiated trials to look at some of these disease-modifying therapies and compare the populations. There's an abstract we've submitted about the natural history of placebo groups, and also there's a lot of advisory board involvement in terms of trying to determine these unmet needs and also to try to educate. I do a lot of education through foundations to try to educate patients to be aware of these differences and also raise awareness to get people involved in clinical trials in their areas and to ask about clinical trials in whatever part of the country they live in. And finally, this is my summary. I think I'm about a minute over, so I think at breakfast we said I could have 11.5 minutes maybe. So here's a summary. So basically, in summary, there's a growing body of research over the past 10 years. Most of the research that's been done in African Americans and MS has been over the past 10 years. And out of 60,000 articles about MS in general, there are about 100 concerning African Americans and MS, and most of those in the past 10 years. So we're moving in the right direction, but we still have a lot of work to do. And we still have a lot of work to do in terms of determining the true incidence. As I said, 6 to 17% is estimated, but certainly in my population it's at least 25 to 30%. So there's some disparities there. And then certainly the other issue is looking at recruitment in clinical trials to make sure that the medications that we're giving, that we can generalize those results to our populations and kind of say with confidence that we know these work in this population of people. So I thank you so much for your time and attention, and I'll hand it over to Lilyana.
Thank Dr. Perkerin for giving me the opportunity to speak today. I am a neurologist at the University of Southern California and also a researcher in Hispanic multiple sclerosis. And if you can bring up my slides, thank you. So here are my disclosures, and let's see, how do sorry. Here are my disclosures, and we'll go on. So as you mentioned, as Dr. Williams mentioned about African Americans and multiple sclerosis, that there is a handful of investigations or studies that have been done. There's even fewer in multiple sclerosis relating to the Latino population, particularly here in the United States. When I think about Hispanics, or a new, sort of a term that's come up, Hispanicity, and when I think also about multiple sclerosis and the complexity of how we believe that the disease starts, you start thinking that there has to be some factors that would lead to a specific, perhaps, phenotype or behavior of the disease. In this case, we think about, we don't have a specific cause to MS, but we certainly know that there's genetic factors that are important in the susceptibility, where in the whites it has been studies using genome-wide data suggesting that there's over 140 candidate genes that could play a role in the immune function. We certainly know that there's environmental risk factors from vitamin D deficiency and infectious mono and geography, latitude, that could contribute to the risk of MS. And so if we have all of this, then, and you have a population that differs in those risk factors, then we certainly will have a difference in prevalence perhaps, but also a difference in the behavior of the disease. So back when I was a fellow, and won't say the year, but basically I knew that there was a handful of studies, at least throughout Latin America, suggesting that the prevalence of MS was quite low. Of course, as we alluded before, there is no information whatsoever of MS, but there were certain studies suggesting that in the last 15 to 20 years, there seemed to be emerging more MS cases. And this was not necessarily related to having much more knowledge of MS, neurologist or MRI, but it was the fact that they were finding not chronic conditions or cases, but very early on cases. And this was, again, reports from Latin America. Of course, when I started looking around, there was not a single registry or knowledge about Hispanic MS. This was in early, 2006, 2008. And so we decided, along with my mentors, that I would start building a registry. It started off with a very simple collection of clinical cases being observed at USC. USC has one of the largest MS centers in Southern California, where we see about 3,000 cases a year coming our way, along with another 1,000 cases in the county hospital. And when I would, certainly see cases, I would say, well, why do I see about 80% of my cases being Latino? I know we live in Los Angeles, and there's a large population, particularly in the LA County Hospital, and they were not the common type of MS patient that was described, where it would be mostly of Northern European background. So we started collecting, and we were able to start seeing some differences, specifically when we compared it to our white population. And so here we had a great situation in LA where we could, use that diversity to start examining relationships as well. And one of the things that, a couple of things that we have been able to see is that it appears that the age of onset, particularly, with their first demyelinating event and even diagnosis, it's about maybe 2 to 5 years earlier than whites when we compare them. This has not only been seen by me, but it has also been replicated in another population-based study from Kaiser Permanente, which again, it's another sort of source population that we can use. And so, but the other interesting thing was that when you looked at by migration status and birth status, you can start seeing also some additional differences. And we've known from the MS literature that risk factors, particularly before puberty, seem to impart an effect in the age of onset of MS. And so one of the things that we were seeing is that in the Hispanic, if you are US born, you will start also earlier with multiple sclerosis compared to your migrant counterpart. But what was also of importance is that the migrant was not coming to the US, or at least what we're seeing is they are not arriving in the US with MS. They are starting their disease about 10 to 15 years later. And so that's been very important information that we have recently published. And so again, it's telling us that there's a disparity. It could be obviously environmental risk factors, but also access to care, quality of care that's leading to this ambulatory disability. What we are also seeing, just like in the African American, is that they are at twice the risk of presenting with optic neuritis, or again, that inflammation in the eye that can lead to blindness, but also with walking difficulties or the transverse myelitis, spinal cord syndrome, that again is twice the risk. We are also looking at other risk factors, vitamin D deficiency, which we know is an important risk factor to MS, and there lies a paradox, because you have again, you have the Hispanic having lower vitamin D levels, and we have yet to answer if that will also be a risk factor for MS. But of importance, going back to that spinal cord syndrome, is that this spinal cord syndromes, at least 20% of them will present with a very specific feature. I'll go back to that. That has very long spinal cord lesions, and we call them LSCLs. And LSCLs are quite rare. They are not found hardly in the white population, but what is interesting is that they are reported in Asian populations, studies coming from Japan, China, where commonly one will think about another condition not known as multiple sclerosis, but neuromyelitis optica. And so this is quite also a feature of other autoimmune conditions, but here you have a phenomenon which is, again, it's being multiple sclerosis, and you're finding this setting. Of course, this is highly concerning because, one, we have found it to be individuals that do have these spinal cord lesions are at quite very high risk of getting ambulatory disability. But because of the background of literature suggesting this to be much more of a common feature with optical spinal forms of MS, and also in the Asian population, we started collecting, part of the registry is to collect genome-wide data and immune measures. But using genome-wide data, we looked at their genetic global ancestry, and using ancestral informative markers, we've been able to note in a very preliminary analysis, noting that the individuals with very high proportions of Asian, Native American background within this Latino population are the ones that are increased risk of developing these spinal cord lesions. And so it's sort of opening our eyes to using this diversity or complex genetic background within the Latino population to answer questions about phenotype, but also eventually to look at the immune response or an immune function within these individuals, which may be different than what we usually know about typical MS. So additional data that we are working together is using with the Kaiser Permanente data, and this is data that has been given to me by Dr. Langer Gold, who is my mentor, and here she is in a case control fashion. She is following newly diagnosed MS patients of Black, Hispanic, and white background, and from here you can start noting already that there are specific differences that are very interesting because they are being, again, it sort of brings back to my registry that they're very similar things that she's finding. And one, they're always, the Hispanic is a lot much younger from participation. I don't have the data here from diagnosis, but they will also be much younger compared to the whites and Blacks. But also when you look at the infectious mono, history of mono, it is quite rare in the Hispanic as well as family history. So there is a lot for us to do here, but it's sort of informing us that perhaps the biology of the disease differs between Hispanics, Blacks, and whites. And how may this be important? Well, it will certainly, we'll have to come back to clinical trials and treatment response if we do think it's, the immune system may be behaving differently. We already know that there's probably differences between brain and spinal cord, differences in the impact and immune response. So we are moving forward. But something that I haven't touched upon, as I'm working with genetic and environmental risk factors within this registry, I realized that coming together with the community was so important. And some of the small focus groups that I started doing was related actually to a Clinical Translational Science Institute community project that I was involved, that was really just to go out there and start talking to my Latinos about what I was doing in research. And as I started talking to them, I realized that there was very lack of involvement with the National MS Society. They had perceptions about what caused their MS to be completely out of norm of what is out there, and that they hardly even visited whatever page existed that was translated in Spanish. And so of course, concerns became quite big about, non-biological factors affecting what I was seeing as disability. And so we started, one, of course, getting together with the community and coming together with Biogen and Immigration Health Initiative from USC, which actually the Immigration Health Initiative got involved because of what I had seen differently with the migrants having more disability. And together we have sort of built a program that will capacitate, or the whole objective is to capacitate community health leaders to go out there and talk about MS, but also together with USC Cinema, we plan to develop a video, a small film, talking about MS, and hopefully we'll use several generations speaking Spanish and English to note what his MS may be. And I leave you with that. There's a lot to do, including trying to answer what the prevalence is in this country, which will probably lead us to a lot more questions than answers. And thank you for your time.
Hello, everyone. I'm so glad to be here. I'm happy to have the chance to tell you about a new research initiative for MS called I Conquer MS, and to describe our efforts to build a diverse community of empowered research participants. Maybe some of you in the audience today will be able to help us build this community, and maybe we can help you in your mission too, if you would like access to outcomes data and or other resources that we may be building. Do I push this? Which button do I push? Okay, got it. All right. So what is I Conquer MS? It's a virtual national community of people with MS who are joining forces to work with researchers and others for the purpose of conquering MS, which, as you've just heard, if you didn't know much about it, it's a devastating disease. The hub of this community is a web portal at iconquerms.org, where people sign up to participate, to learn about the research studies that we're conducting, to contribute data for research, to communicate with one another, and so on. And this is just a screenshot of the homepage so that you can see what it looks like. So I Conquer MS is by and for people living with MS. This means that I Conquer MS is focused on research topics that are important to people living with MS, such as risk factors, who will respond better to which treatments of the many treatments that are available. They're interested in particular symptoms that are bothering them. They're interested in therapies that aren't drugs, and a lot of different things besides. It's also governed by people with MS, and that's very important. They are in the driver's seat, which is not where they usually are when it comes to research. We are in the very early phases of this initiative. The portal went live just late last year, and we began a national recruitment campaign in February. And so far we have over 1,500 people who have joined, so we're off to a good start. And now we're starting to discuss specific research projects that we might conduct. So you may be wondering who I'm referring to when I say we in conjunction with I Conquer MS. Well, I Conquer MS is the result of a collaboration involving my organization, a nonprofit called Accelerated Cure Project, a leading health communications firm, FK Healthcare, because really I Conquer MS has a large communications component to it. The Complex Adaptive Systems Initiative at Arizona State University, and a group of highly engaged people with MS and other stakeholders who have guided our efforts along the way and are part of I Conquer MS's governance structure. Our initial funding comes from the Patient-Centered Outcomes Research Institute, or PCORI, which is a nonprofit organization authorized by the Affordable Care Act that supports patient-centered research. Now, PCORI funded us to create I Conquer MS as the MS-focused node in an extensive network called PCORNet. I Conquer MS is one of 18 patient-powered research networks, which are generally disease-centric networks set up by nonprofits like Accelerated Cure. There are also 11 clinical data research networks which aggregate data held by major healthcare providers such as Johns Hopkins. And all of us 29 networks are linked together at the data level so that we can conduct large-scale collaborative studies. So potentially we could leverage data beyond that which we hold given to us by our participants to explore significant MS research questions. So what does patient-powered research mean to us? First of all, it means valuing, obtaining, and using the experience, opinions, and knowledge that only people with MS have. As one of our participants recently put it, people with MS hold the pieces to the puzzle. Second, it means that research is powered by patient participants. Nothing important can happen unless significant numbers of people with MS commit to making it happen. And then finally, it means not viewing people with MS only as research subjects, say as sources of samples and data, but including them in all aspects of the research process. And let me elaborate on that a little bit. So participants in our community can power research in a number of ways as they so choose. They can contribute ideas, they can contribute questions or personal experiences that can become research topics for I Conquer MS studies. They set the research agenda in collaboration with other stakeholders, such as scientists and funders. They can provide input on the goals and the design of individual studies. For instance, we will open up study protocols for input by the community. Not only does this ensure that people with MS benefit from the resulting research, but it will also make for more successful studies with greater impact, so it'll benefit the researcher as well. Of course, when studies are launched, participants can contribute their data and their biosamples for research. And moreover, when the data is collected, they can continue participating through the analysis and the dissemination of the results. And importantly, they can encourage others in the MS community to also get involved, which many of our participants are already doing in a variety of ways. So an important part of our work ahead is to reach and invite as many people with MS as possible to join I Conquer MS. Not only do we want to extend this invitation far and wide, but we also hope that those who respond will be representative of the American MS population in all of its diversity. And I know I'm preaching to the choir here, but I'm going to go ahead and do it. Building a diverse patient community is going to do a number of things. It will ensure that the ideas and opinions expressed to shape I Conquer MS as it develops are broad and inclusive. It will ensure that our research agenda meets everybody's needs, not just the needs of a narrow segment, for example, those who traditionally have been included in research studies in the past. And it will ensure that the benefits of I Conquer MS research are distributed equitably and evenly because those research results reflect the entire MS population of this country. Our funders at PCORI are also focused on achieving diversity within PCORNet as a whole. And the categories that they ask us as PPRNs to report on include race, ethnicity, socioeconomic status, health literacy, severity of disease, and age. So those are some of the categories that we will be tracking. As we make plans toward building a representative community of Americans with MS, we've identified a few challenges that have to be addressed. The first is very fundamental. How can we tell how well we're doing without knowing what our goals should be? So as was previously mentioned, there's no national registry. There is no comprehensive epidemiological survey of MS. There's no national healthcare system that we can draw from. So therefore, all we can do is to estimate how many people in the US have MS and estimate how this number breaks down in terms of racial, ethnic, age groups, et cetera, based on the data that does exist. I wanted to point out a couple of interesting things that have appeared in research recently. Prevalence and incidence are studied in certain segments of MS from time to time. And even though MS has been historically considered a white person's or actually a white woman's disease, there's been a couple of recent studies that indicate that African Americans may actually have a higher risk of MS, higher than white Americans and higher than Asians and Hispanics. So I think that will be, we'll see how that plays out, but I think that's interesting. Rumor has it that the NMQF is working on a prevalence map of MS. So naturally, we were very excited to hear about that because such a map could be really helpful to us in terms of setting our goals. The second challenge involves reaching everyone with MS when we only have a limited communications budget. For example, a lot of people who have a medical condition learn about research opportunities through their healthcare providers. So if we want to reach people with MS through their doctors and nurses and healthcare providers, which we do, but if we only approach the MS specialty clinics that see thousands of MS patients a year, because that's easy to do and we can find them, we're going to miss a lot of people. So we need to branch out and try to reach other types of providers as well. If we hope to reach non-English speakers, we would also need to translate our materials and instruments into other languages, such as Spanish. And then finally, we may need to develop different types of messages in order to appeal to different audiences. So as we develop our mix of strategies and tactics, we welcome any and all suggestions about cost-effective outreach methods that could help our communications budget stretch as far as possible and to help us reach as many people with MS as possible. Finally, once we do reach people with MS and present our messages to them and invite them to come and join I Conquer MS, we need to overcome possibly another set of additional barriers. For example, some people, as we've heard, are suspicious of research, or they focus on the potential harms that may come, either to themselves or to their family if they participate in the study. So, why would they take the chance? In terms of technology, iConquer-MS does require internet connectivity. It's not something that you would go to your doctor or your clinic to do. And not everybody has access to the internet, although certainly that's growing. But according to the Pew Research Center, there is still a racial digital divide, which works against our recruiting minority groups. The Pew Research Center also says that African Americans and Hispanics are more likely than white Americans to rely on smartphones for going online, meaning that for one thing, iConquer-MS needs to be upgraded to be more mobile friendly than it is currently. However, another thing that they reported is that smartphone-dependent Americans sometimes have lower incomes and sometimes have to shut off their service for a while, or they might max out their data usage. So this obviously will hinder regular participation in an internet-based study. Finally, there are issues that affect recruitment across the board, that cut across a lot of different groups. Many people with MS are busy with things like work, with family, etc. They may not grasp the value of participating, especially early on before we have any results to report. And then finally, MS can affect a number of different functional areas. So if you have a hard time seeing, if you have a hard time typing, if you have crushing fatigue, or if you're depressed, then you may not be able to or may not feel like participating in an online study or maybe any kind of study. So what can we do to meet these challenges? Well, here are some of our ideas. First of all, our governing board should reflect the diversity of the MS population of America. I'd say we've made a start here, but we still have more to do. One piece of advice we've gotten is to work with third-party intermediaries in healthcare, such as the National... Excellent, I'm getting applause before I finished. Love it, okay. The National Black Nurses Association, the National Hispanic Medical Association. I think we heard about the National Medical Association, the National Association of Community Health Centers. Ask them to help in reaching their minority and low-income MS patients. We have begun to collaborate with other MS organizations and with biopharma companies like Biogen, we'll hear from in a minute, who are also striving, like us, to learn about and meet the needs of a diverse population. We can identify best practices from other research initiatives, such as our fellow patient-powered research networks that have similar enrollment goals. We need to develop messages that resonate especially well with underrepresented groups and address their concerns. So, for example, we could make it clear that becoming active in iConquer-MS, where, again, they're in the driver's seat, is a good way to focus research on the things they want it to do. And finally, we have communication tools on iConquer-MS. For example, we have a discussion forum. So we can use those tools to start dialogues about this topic, to share our progress as we make it, and then to listen and learn from our participants. So to conclude, if you can help us connect with people with MS to help grow our community, or if iConquer-MS can be of assistance in your work, I hope you will let me know. I would love it if you would visit iConquerMS.org, check it out, and sign up if you have an interest in MS. You don't need to have MS in order to participate in the site and to join. My contact information is here for any follow-ups, and thanks again for the opportunity to be here today.
So let's see, am I on? Well, good afternoon. I really appreciate the passion over that table there, because it's late in the day. You've had a full day of presentations, and I'm sure your energy is starting to go south. My name is Javier Barrientos, and I happen to lead the Global Diversity and Inclusion function for Biogen. And my role is to facilitate an integrated approach to looking at how we can positively leverage differences in all aspects of the work that Biogen does. And whether that be the workforce, the patients, or our suppliers. We, as a company, we discovered, develop, and deliver innovative therapies to improve our patients' lives when it comes to neurodegenerative diseases, autoimmune diseases, and blood disorders. We know that cutting-edge science can have a great impact in changing the course of devastating diseases such as MS. And we are, of course, very proud of having been part of the revolution that's been happening over the last decade in the MS space by introducing innovative therapies that are really transforming the standard of care for patients. We're also hoping to take that to other disease areas where there is high unmet medical needs. And we heard in the prior panel some of those areas. We're talking about lupus, sickle cell anemia, and B thalassemia. There is a lot that needs to remain to be done in the MS space, in these other therapeutic areas. But we've begun with a 5-year plan, and let me see if this works. Perfect. The approach that we have, as I mentioned earlier, is to create this integrated look at how diversity plays in all aspects of the work that we do. And of course, to create this approach, patients are really at the center. In 2012, we launched our 5-year plan to drive to a state of sustainable inclusion. And you can see that, in every effort that we undertake, whether it be in the patient, again, workforce or suppliers, we begin by taking a step of creating deep awareness and understanding the needs of our patients. And the important thing here to know is that we don't stop at the awareness. So we then own that awareness and take action. And when we begin to take action, we may not have all the answers. So by no means do we think we have all the answers. But what we do have is a commitment to learn as we take these steps, evaluate, and continue to improve so that we can create ever more inclusive results and awareness about the needs of diverse populations. The important here to consider is that we're trying to embed differences in everything we do, and that we are trying to earn the trust of the patients that we work with. And we know when we achieve a sustainable state of inclusion when we have really been able to engage all of the communities that we serve, and through our partnerships with the medical community and the patient community in a collaborative effort. The patients, of course, are at the center, as I mentioned. And understanding patient perspectives, we believe, is going to lead to really advance the way we do research and to creating more innovative and meaningful treatments that better the lives of and quality of life of our patients. So the insights that we're gaining from our collaborations with our medical community and patient community are beginning to expand our understanding of how MS shows up in underserved populations. And specifically, we are bringing a lot of attention to the issue of underrepresentation in clinical trials for African Americans and Hispanics that you've been hearing about, as well as the substandard outcomes and results in treatment for these populations. We felt very strongly that it was our responsibility to commit ourselves to address the gaps that exist today by developing collaborative approaches that could advance the treatment of MS in underserved populations. this is how we created what we call internally MS Up, or MS in underserved populations. It was born from that spirit. And the idea here was to assemble a cross-functional team of colleagues in the company that will help begin to address this challenge of the health disparities gap. And quickly we began to assemble partnerships with the medical community and patient organizations to be able to take on this challenge. Essentially, what we're trying to do with MS Up is to improve outcomes among racial minorities in the US. Now I'm going to show you the work that we're doing in terms of our three-pronged approach, a collaborative approach. In this graphic, you see that we have three pillars to the work that we're doing. Data generation, which is all about increasing information on clinical outcomes and treatment response among minority populations. The internal education, which is about increasing awareness among the Biogen community about minority patients and how we might be able to help address the challenge of healthcare disparities. And then the external education piece, which is about increasing awareness of MS among minority populations and improving the quality of educational resources that minority patients have today. What you don't see represented in this graph is two important elements. One is the interdependence of these three pillars. They really drive each other. Data generation influences our internal education, and that influences external education. And I'm going to be talking about that interdependence in a second with a couple of examples. The other thing that you don't see in this graph that is vital is the notion of collaboration between us, the Biogen, and the medical and patient community. Without that collaboration, we won't be able to get much traction and really make a difference. So now let me give you a few examples of how this three-prong approach is working. On the data generation side, we've been looking at the issue of clinical trials. You heard from some of the speakers in this panel today and the panel prior that that's a great area of urgency. So we're expanding the representation of minorities in clinical trials by expanding the base of partners that we've been working with to enroll patients into clinical trials, especially new partnerships that we haven't worked with before that have already rich and deep connections with minority populations. We're also learning, many of the strategies have been mentioned before if you were here for the clinical trials panel before, exploring new strategies to engage minority patients into clinical trials so that we can generate the data that's needed to be able to create very effective approaches. Internally, I want to call your attention to three things that we've been doing. One thing, the first thing we started to do is to look at cultural competence, how we as a company can become really culturally competent in addressing the needs of our patients, whether they present socioeconomic, cultural, linguistic differences. And we put in partnership with the MGH Harvard Healthcare Disparities Institute, we have created a training and cultural competency for all of our patient service team, and that's about 400 people that interface with the patients so that they have the tools to be more effective in assisting those patients. We've also created a visiting professor programs. Dr. Amezcua and Dr. Williams are here today. We're our first guests, and I'm proud to say that to this day, that's the best attended, most well-received visiting professors program that we have held at Biogen. They spend nearly a day and a half with us educating a wide cross-section of employees in the company around the needs of minority patients. So those are two examples of on the internal efforts that we're driving. The other one that I want to call your attention to is that I believe we're the first, if not one of the first companies, to send 3 of our leaders to the Harvard Healthcare Disparities Institute Fellowship. They'll be starting this year as a 1-year program, and they have been, these 3 leaders from Biogen are charged with really getting a deep understanding and doing actual learning projects that will help the company become more effective again at closing the healthcare disparities gap on several fronts. Each of the participants that are attending the program have different areas of focus. On the external side, we heard briefly from Dr. Williams before that there has been a publication. This is an effort that actually Biogen has supported. We convene a steering committee of experts in MS who have great knowledge around minority populations. And one of the outcomes of that convening this steering committee of experts catalyzed in the development of a manuscript that was recently published in Neurology Practice. I highly encourage any and all of you who are here today, if you haven't read it, to really read this article, because it's really eye-opening. What is really important, it's really a call to action to change the game around how to bring better healthcare access to the broader MS community, and especially to underserved populations. The last thing on external education, two things I want to add on external education. One is I hope that in the Q&A you asked Dr. Amezcua about a program that we are sponsoring also called Promotoras. And this is a really exciting and innovative program that is happening in Southern California to train community-based workers to bring a greater understanding of MS in their own term and in their own language to the communities where they live. So I'll let, and I hope you ask about this, and if you don't, I will, to Dr. Amezcua about Promotoras, because I'm very excited about this approach. I want to leave you also with a last story around how these worlds of internal and external education are interdependent and connect with each other. Last September, we brought the Biogen Diversity Council, which is a group of senior executives that oversee our entire diversity strategy, to the Caribbean Neurological Center in Puerto Rico. And the purpose was to really give them a first-hand experience of how you deal with MS in a context where you're working mostly with Hispanic patients. And we had quite a bit of learning that happened from that visit. And one of the things that we learned, it was from a presentation from one of the nurses that said that she was the only one, or maybe one of 2 nurses in the island that were trained to work with MS patients. And naturally, at the center, having nearly 2,000 patients, she was a bit overwhelmed. And she was asking, if one of the things that could make a big difference for her was to have culturally linguistic appropriate materials to educate and work with her patients. So we've taken on that challenge, and we've been partnering with the CNC to create better educational materials, but also we've been exploring how to create education opportunities for nurses in the islands, so that a huge patient population does not have to rely on the services of just one nurse. In sum, I want to just highlight that we are trying to drive better outcomes for minority patients. That's really our commitment. And I want you to understand, and you again, probably preaching to the choir here, but none of this will happen without collaboration. And I have to thank, Dr. Amezcua, Dr. Williams, and to Hollie, because it's this type of collaboration that is really moving the needle forward. And we're hoping that some of you in this audience, maybe that table there that seems so excited, will take us on to, we're looking for future partnership and collaborations to really keep going. We've made great strides, but by no means have we conquered the issue. There's a lot that remains to be done. Our collaborative three-prong approach also has a second set of hopes here. Our hope is that we're using this, what we're learning in MS, to be able to scale it and leverage it so that we can apply it to other disease areas such as sickle cell anemia, beta thalassemia. I think I confused those two right there. And lupus, which if you were here for the panel before, you heard about the immense need that exists in the lupus world, where there's only has been one therapy in the last 54 years. So certainly a lot to be done. I thank you for your attention and look forward to your questions in the Q&A.
Thank you to each of the panelists. I think we could start with Mr. Barrientos' question to Dr. Amezcua about promotores.
Certainly.
Just elaborate more, yeah.
I talked briefly about it, but it is a concept that obviously is not new in the world of healthcare, where it's community healthcare workers or lay individuals that have been used obviously for diabetes and a stroke and a heart disease, where I thought using that model, if we could use it for multiple sclerosis, would definitely lead us to understanding a little bit more and delivering more education to the MS community. Again, like I was talking earlier, where I started taking my research to the community, I realized the enormous amount of lack of awareness that existed within them, even though they had disease for over 10 years. And that has to do, of course, a lot with the fact that the current, even the National MS Society, which I am part of as an ad board member, that there's still a lot of need of even just translating the page into the correct type of Spanish, and creating those materials that are culturally sensitive. But realizing that the Hispanic community, they like one-on-one. They like people to talk to each other. It's not just about reading something on a web page. And so there's that differences in delivering material to them, and I think it goes the same way for different communities. So we need to we need to understand that, and something that Hollie said, which is very interesting, and I do agree with that, is that the smartphone issue, and I think that might be something for Hispanics, where they they rely also on the smartphone. But going back to that community healthcare worker, is that we want them to carry information to the Hispanic, and then the Hispanic affected with MS and their families, because when we treat MS in a Hispanic, we have to talk not just to the parents, we need to talk to grandma. Grandma comes to the clinic, and so it's a whole entourage of individuals coming to the clinic, and so we have to be able to be culturally sensitive to the MS patient and the generations that come with them. So I'm really excited about this project that Biogen has so nicely accepted to support me with, and look forward to those outcomes.
And unfortunately, due to timing, we're going to have to cut short or end our question and answer portion, but I would encourage each of you to, if you have questions for the panelists, I'm sure they will be available throughout the conference to answer them. And so if we could just give another round of applause to the panelists and for all the information they gave us.